Hi, everyone. My name is Heather Hampel, and I'm a genetic counselor at The Ohio State University, and I represent the National Society of Genetic Counselors on the National Colon Cancer Roundtable. I'm also co-chair of the Family History and Early Age Onset Work Group, and we're pleased to be presenting this next breakout session for you, titled Early Age Onset Colorectal Cancer Screening Updates. We have a fantastic panel of speakers for you today who you will all know very, very well. They barely need an introduction, but I'm going to introduce them all now. Then they will speak in turn. I have a couple slides at the end, and then we're going to hopefully have a really great discussion. So we left a lot of time for Q&A. So please send your questions like you've been doing all afternoon, and we will save all of the questions until the end and do them as a group. I'm pleased to introduce our speakers for this afternoon. Our first speaker will be Rebecca Siegel, who's been a descriptive epidemiologist at the American Cancer Society for 15 years and is currently Senior Scientific Director of Surveillance Research. In addition to leading the annual Cancer Statistics article, she oversees production of 8 cancer facts and figures educational reports and publishes scientific articles across the cancer continuum. Her primary research interest is in colorectal cancer occurrence with a focus on early onset colorectal cancer, as you'll see today. Our second speaker is Jordan Karlitz, who is an associate professor at Tulane University School of Medicine, where he founded the Hereditary GI Cancer and Genetics Program at the Tulane Cancer Center. He's also the Associate Program Director of the Gastroenterology Fellowship Program at Tulane and the Fellowship Site Director at the Southeast Louisiana Veterans Healthcare System. His clinical interest and research centers on early onset colorectal cancer and familial colon cancer syndromes, including Lynch syndrome. And our last speaker this afternoon is Samir Gupta. Dr. Gupta is a professor of medicine at the University of California in San Diego and chief of the section of gastroenterology at the Department of Veteran Affairs San Diego Healthcare System. He serves as the chair of the National Comprehensive Cancer Network's annual Genetic/Familial High-Risk Assessment Colorectal Guidelines and as a member of the U.S. Multi-Society Task Force on Colorectal Cancer. So pleased to introduce everybody, and we will kick things off with Dr. Siegel.
Can everyone see my slides?
Yes.
Okay, all right. Good afternoon, everyone, and thank you to Caleb and the Roundtable for inviting me to be part of what I think is going to be a really great discussion today on opportunities for mitigating the burden of early onset colorectal cancer. As Heather said, I am a descriptive epidemiologist at the American Cancer Society, and I'm going to provide a backdrop for the conversation today by sharing the current epidemiology through a lens of opportunities for action. This conversation couldn't be happening at a more appropriate time because, as I'm sure you all are aware, the task force recently issued draft recommendations lowering the age that they recommend to begin screening for those at average risk from 50 to 45. And this is consistent with the ACS guidelines that were issued in 2018. I know you're all familiar with this figure showing the overall long-term declines in colorectal cancer in the US, but it's really appropriate for this conversation to highlight the fact that the US is really fairly unique in this progress. And there are a lot of high-income countries that are still experiencing increasing incidence in older adults, and these include the Netherlands and Norway. And the reason that we are seeing this progress, especially in the last few decades, is because of the widespread uptake of screening in people 50 and older. So we feel like there's a lot of potential to at least dampen the rising incidence in young adults. These figures show incidence trends based on cancer registry data from SEER and NPCR registries that reflect almost 100% of the US population. And they show that incidence rates have been increasing in people under 50 since the mid 90s, and more recently in people a little older, 50 to 64, since 2012. And this is because of the strong birth cohort effect in these trends, and it's something that we expected. You'll also notice that the patterns in men and women are quite similar despite higher rates in men, especially in the older age group. About a decade after incidence began increasing, we were seeing increasing mortality rates in people under 50. And the pace of the increase right now is a little bit faster in men than in women. And that's probably at least partly because women are diagnosed earlier. 36% of women under 50 are diagnosed at a localized stage of disease compared to 31% of men. And this is probably partly due to just more healthcare interactions for women. I also like to point out that I read in the literature all the time that colorectal cancer is a preventable disease, but it's important to note that it's still the leading cause of cancer death in men under 50. Patterns for mortality are also beginning to change for older adults, similar to incidence, in that we're seeing a deceleration in the declines from 3% annually to just 0.6% since 2005. Screening people beginning at 45 will have a larger impact on rates in people in their 50s than it will for people in their 40s. Part of the reason that we're seeing increasing mortality rates is because it's advanced stage disease driving the incidence trends. This figure shows the pattern that was similar for all stages of disease early on, and since 2006 has been driven by regional and distant stage disease, which are increasing at about 2.5% annually compared to stable rates for a localized stage disease. So this shows an opportunity to shift the stage at diagnosis with more appropriate screening. Here we have the stage distribution for patients under 50 in red versus those 50 and older in blue. Young patients are much more likely to be diagnosed with advanced stage disease, with 1 in 4 diagnosed with metastatic disease compared to 1 in 5 of those 50 and older. And of course, this is largely because of screening in older patients, but it's been estimated by one study that even after accounting for screening, young patients are 40% more likely to be diagnosed with advanced stage. And this is partly due to delays in diagnosis, some of which are potentially avoidable. And we're going to hear more about that a little bit later. Because as we know, delays in diagnosis can literally mean the difference between life and death. These are 5-year relative survival rates by stage at diagnosis, and survival drops steeply from 78% for patients diagnosed with regional stage disease to 21% for distant stage diagnoses. It's been estimated that we could avert 40% of colorectal cancer deaths overall if we could shift that stage at diagnosis from stage 4 to stage 3. Decades of declining risk in older patients coinciding with increasing risk in young patients has rapidly shifted the patient population younger. The median age at diagnosis has dropped from 72 to 66 in less than 2 decades, also supporting a younger screening age. Although the absolute risk of disease for people under 50 is, of course, substantially lower than it is for older patients, the burden is surprisingly large. We're expecting in 2020 18,000 new cases of colorectal cancer being diagnosed in people in their 40s or younger, and more than 3,600 deaths in this age group. And this is the equivalent of 49 new cases per day and 10 deaths per day. These patients are unique in many ways from their older counterparts, and many of which have not been fully appreciated by clinicians. And one of these is that they have the additional burden of being caretakers. Most of them are caring for young children. Another unique factor is the preponderance of left-sided tumors, 62% versus 42% in older patients, especially rectal tumors. And the reason this is important is because treatment for rectal cancer is much more likely to leave patients with sexual dysfunction and infertility, which is more relevant for younger patients. On the flip side, left-sided tumors offer more of an opportunity for earlier stage diagnosis because they're easier to detect through screening, and especially rectal cancer often presents with symptoms earlier. The age distribution for young patients also bodes well for screening opportunities. More than 2/3 of patients are in their 40s. Many of these should be screened before 45 because of a family history, which we'll learn about in a few minutes. And close to half of these patients are 45 to 49, and so now should begin screening at 45. One of the criticisms of beginning average risk screening at 45 has been that early onset tumors are really different from those in older adults, and that screening may not be effective. And it's a legitimate concern. But more and more research is indicating that those really unique tumors are confined more to the youngest adults, and that patients in their 40s have tumors that are very similar to people in their 50s. So the key takeaways here are that the epidemiology really supports an opportunity for mitigating the burden through earlier diagnosis, both via screening for average risk individuals at 45 or even earlier with a family history, as well as reducing delays in diagnosis through earlier follow-up. Thank you so much for your attention.
While Dr. Karlitz brings up his slides, this is just a reminder to enter your questions into CVent. That'll help us with our discussion after our talks.
Okay, can everyone see my slides?
Yes.
Okay, great. So the title, first off, I'm very grateful for being invited to speak today at the NCCRT with such great colleagues and experts on early onset colorectal cancer. And the title of my portion of the talk is A Different Perspective on the Utilization of SEER Cancer Data to Understand Early Age Onset Colorectal Cancer. So traditionally, as we all know, SEER data is often analyzed in age group blocks. So we may pool 30 to 39-year-olds together, 40 to 49, et cetera. And one of the rationales for doing this is that pooling of age groups can increase statistical power for analyses. However, it's important to point out that you could potentially miss certain trends if you pool age blocks. So there's certainly pros and cons to doing it. But the large size of the SEER database actually allows analyses in 1-year age increments. And what this could do is it could really allow for a quote unquote high definition view of incidence rate trends, particularly in those approaching screening age, which, as we know, is a key group to understand because of the current controversy, although it seems to be leaning towards 45 now, between screening at age 45 versus 50. So just for people that are not familiar with the SEER database, this is a map of the different states and regions that utilize, that are part of the SEER data project. The two most common databases you'll see used are SEER9 and SEER18. SEER9 started in 1975, where SEER18 is available starting in 2000. So I want to go into a paper that we just published in JAMA Network Open, which is entitled Trends in the Incidence of Colorectal Cancer in the US Among Those Approaching Screening Age. So we actually used a unique methodology where we analyzed CR18 colorectal cancer incidence rates in 1-year age increments, as opposed to grouping people into age group blocks. And the main question we wanted to answer is, what is the increase in the colorectal cancer incidence rate from age 49 to 50 when large segments of the population begin average risk screening? So as you can see, there are a very large number of cases we analyzed, about 170,000. And the key point here is that the incidence rate increased a staggering 46.1% just from the age of 49 to the age of 50. So here you can see the figure. So here on the x-axis, you could see yearly age, so 30, 31, 32, et cetera. And here you could see incidence rate on the y-axis. And you can see there's a gentle upslope until you hit 49, and then there's a very steep increase of 46% from age 49 to 50. And these findings really support a large undetected preclinical colorectal cancer burden prior to age 50 that's ultimately diagnosed with screening at age 50. And these incidence rates are not reflected in the SEER incidence rates because people under 50 usually are not undergoing screening. And I think this steep inflection argues for beginning screening at age 45. Another key takeaway from our study is that we actually looked at yearly case counts and broke them down by age. And we found that if you extrapolate to all 50 states, there are approximately 129,000 cases of colorectal cancer between the ages of 45 and 50 during our study population from 2000 to 2015. So that's really a very, very large number of colorectal cancers that could potentially be prevented altogether, or at least diagnosed at an earlier stage with earlier screening. So this age 49 to 50 incidence inflection was reproducible in all US regions, in men and women, in white and Black populations, and in both colon and rectal cancer. And the main thing that unifies these populations is screening at age 50. So the fact that we're seeing the same pattern in these different groups really supports that this incidence increase from 49 to 50 is due to a screening effect as opposed to advancing age alone. So here you can see, when you break it down by region, you can see that each region, so South, Northeast, Midwest, West, if the same inflection is seen between ages 49 and 50, obviously there are slight differences in how steep it is, which may depend on screening rates and colorectal cancer burden in a particular region. And here you can see that males and females also show this similar inflection, although it's greater in males than females. Very similar inflection in both white and Black populations, although you can see the incidence rates in general are higher in the Black population compared to the white population, but that same inflection is seen from age 49 to 50. And here you can see that it's also seen for colon cancer versus rectal cancer. So it is obvious here that the increase is steeper in colon cancer, and we think that is because rectal cancer maybe have a lower percent increase from 49 to 50 because these patients may be more likely to present with symptoms prior to screening detection at age 50. So this is an important slide that looks at stage stratification. So we did basically the same thing as before. Again, on this axis, we have yearly age, and here we have incidence rates, but we broke everything down by stage. And you can see that in situ here, there's a steep incidence rate increase, but you can see the incidence rate in general is much lower than the other stages. You can really see that the localized increase and regional stage increases were the most prominent in the study population, and that distant stage was actually fairly flat. So some key takeaway points from this stage stratification slides are, number one, about 93% of colorectal cancer diagnosed at age 50 are invasive beyond in situ stage, just highlighting the important burden of colorectal cancer in this population. And that localized cancers can't really be disregarded. They're associated with a 10 to 11% 5-year mortality, and most actually require surgery. And I think this really argues against length time bias and that this is a length time bias effect. Our findings argue against this. And if you remember, length time bias is when slower growing and potentially less clinically significant tumors are detected with screening. Another key point is that localized and regional colorectal cancers can be associated with psychological distress, economic burden, and impaired quality of life. So this is a major issue that we're seeing this steep incidence rate increase at age 50. In terms of the flat nature here of the distant cancers, I think this is expected because we believe most of these cancers would probably present before age 50 due to symptoms as opposed to being picked up incidentally during a screening exam. So key take-home points from the study, the steep age 49 to 50 incidence rate increase supports of the presence of a large preclinical cancer burden in patients in their 40s. And the main issue here is that this is not really reflected in observed SEER incidence rates because patients under age 50 are not undergoing screening to detect preclinical cancers. Some arguments historically posed against earlier screening at age 45 have included much lower incidence rates in the 45 to 49-year-old population compared to the 50 to 54 population. But as we could see from our study, this is really a misconception because those between ages of 45 to 49 do not have the advantage of having their colorectal cancers picked up by screening compared to 50 to 54-year-olds. So you're really comparing apples to oranges. 50 to 54-year-olds could have their cancers detected by screening, symptoms, or family history, but those younger generally are only going to have their cancers detected due to symptoms or hopefully earlier screening if they have a strong family history. So this is the last slide. I do want to talk about this is a recent paper that was published by Butterly et al. In the American Journal of Gastroenterology. And in this paper, what they did is they used the New Hampshire colonoscopy registry to compare the prevalence of advanced neoplasia in an average risk screening equivalent group, age 45 to 49 compared to 50 to 54. And the key takeaway point here is that basically advanced neoplasia is very similar in 45 to 49-year-olds and 50 to 54-year-olds, which argues that this population between 45 to 49 is very high risk compared to what has been thought in the past. And that is the end of my section. Thank you.
Good afternoon, everyone. It's an honor for me to have the opportunity to present to the National Colorectal Cancer Roundtable. I want to thank Dr. Hampel for moderating and the NCCRT for inviting me to speak. I'm Samir Gupta, and I'm going to be talking about current opportunities for timely identification of people with early onset colorectal cancer based on family history and symptoms. So I think most people on this webinar know that family history increases the risk for colorectal cancer and also left shifts the age of diagnosis. So for example, regardless of the age of having a first-degree relative with colorectal cancer, the relative risk for colon cancer is increased anywhere from 2 to 3.3 fold. And then in this figure on the right, you can see on the x-axis age and on the y-axis cumulative incidence, and that the age-specific incidence for people with a family history starts to rise about 5 or 10 years earlier compared to those who have no family history. So this, of course, has led to well-established family history-based recommendations for early initiation of screening. For example, the National Comprehensive Cancer Network recommends that if you have one or more first-degree relatives with colorectal cancer, that you start screening at age 40 or 10 years before the earliest relative who is diagnosed with colorectal cancer, and that this test be considered for repeat in 5 years. So one question with regards to family history is really how effective these are for finding people who have cancer. And we did a study recently that was published in Cancer earlier this year. The aim was to estimate the performance of family history-based guidelines for identifying individuals with early onset colorectal cancer. We took advantage of the population-based case control data for individuals age 40 to 49 in the colon cancer family registry who were included between 1998 and 2007. And our goals were to compare the sensitivity and specificity of guidelines from major groups for family history-based screening for identifying people in this age group who had colorectal cancer. And we also estimated the proportion of people who had colon cancer who could have been recommended screening initiation younger than their actual age of diagnosis. This slide shows our primary findings. So we can start off first with the cases. There were 2,473 colorectal cancer cases, and we found that 25% met family history-based criteria for early screening. And this was about the same whether we looked at the American Cancer Society or the National Comprehensive Cancer Network guidelines or those from the AGA. And what this means here is that the sensitivity of the guidelines for picking up people who had early cancer was 25%. So the first take home here is on the plus side, 1 in 4 people with early diagnosis of cancer between 40 and 45 had a family history, but it also meant that 75%, or 3 out of 4 people who had an early diagnosis had no family history whatsoever. And we'll come back to this group in a minute. The other thing that we found is for the people who did in fact meet family history, we estimated that 98% of them, based on the family history guideline, could have had a recommended screening initiation age younger than their actual age of diagnosis. So these patients could have had an opportunity to have their cancer detected earlier or possibly even prevented if family history-based guidelines had been implemented. So really the couple take-homes here from this study is, one, we have an opportunity to do better if we can implement family history-based guidelines. We may have a chance to catch a bunch of people earlier and maybe even prevent cancers. And then the second side, if you look at this glass half empty, is we still need strategies for finding these 3 out of 4 people who have early cancers who have no family history whatsoever. And some of these will be addressed by starting screening at age 45, but there will remain a large number, as Dr. Siegel showed you, over 50% of young onset cases that won't fall into family history criteria and still won't be eligible for screening. So what do we do about them? And I think for them right now, our opportunity is on-time evaluation of symptoms, which is definitely a problem. And there are 2 studies here that show this problem. One is a small single-center case control study where they looked at younger versus older rectal cancer patients and found that the younger patients had a longer median time from symptom onset to healthcare provider evaluation, and a median 121 versus just 21 days for the older individuals, and a longer median time from symptom onset to first course of treatment. So 217 days for the younger patients versus 58 days for the older patients. There's also another study, a single center retrospective study, in which they looked at younger versus older colorectal cancer patients and found that the younger patients had longer time from symptom onset to diagnosis, a median 128 versus 79 days. And also the younger patients had a longer time from first medical visit to diagnosis with a median 31 to 22 days. And I normally emphasize median rather than averages, but I think this is one case where it is worthwhile looking at the averages because they tell us something about the outliers. And you can see here that the average time for the younger patients from symptom onset to diagnosis was 243 versus 154 days. And what this means actually for both groups is that there were a bunch of people who actually had a very long time from their symptom onset to diagnosis. So clearly we can do better here. So we've been trying to do some thinking about, well, what's the messaging for patients and primary care providers to try and get more timely evaluation of signs and symptoms? And this is our initial attempt at thinking about this. So one is that we need to increase identification of red flags, which can include rectal bleeding, abdominal pain, weight loss, and iron deficiency anemia. And the second point is that patients with these symptoms really need to be carefully triaged. And this would be to immediate colonoscopy workup versus other workup and treatment using clinical guidelines, such as those for workup based on iron deficiency anemia or hematochezia, the symptom and sign severity, Obviously, a person who just has minor blood on the toilet paper should be treated very differently than someone who reports bleeding every day for the last 6 months. And also the clinical context. So I would advocate that any person with rectal bleeding needs a rectal exam, because if they have a mass, that's free information and you can know right away what the right thing to do is. And then I think the final piece of this is we need to close the loop. So if we choose not to do an immediate colonoscopy, I think physicians need to have some sort of mandatory follow-up, such as a 30-day follow-up, to make sure that the original signs and symptoms have gotten better, or that there's an alternative diagnosis. And if there is not, these patients need to be triaged to colonoscopy. And the thought is, if we can follow these steps, we can get more timely early onset colorectal cancer diagnosis. Thank you so much for your attention. I'm looking forward to the Q&A.
We're starting to get some questions coming in. Please continue to submit your questions. I just have 2 slides that we wanted to share with the group in regards to what Dr. Gupta had mentioned, which is the 75% of patients with early onset colorectal cancer who do not meet family history criteria for earlier or more frequent colonoscopy. And as he mentioned, right now, the best thing we have for those individuals is timely identification and follow-up of symptoms. But one thing that we've been interested in and that has received a lot of attention in 2020 that we might want to start thinking about for the future is the idea of doing population screening in the general public for inherited cancer syndromes. We've talked here before that about 16% of early onset colon cancer cases are due to a mutation in a cancer gene. Over half of that, a little over 8% are due to Lynch syndrome, which is the most common inherited form of colon cancer. So how can we make sure that everyone is diagnosed with Lynch syndrome early enough in their early 20s so that they can start their colonoscopies early enough and do them frequently? And this, the best way, assuming that not everybody has a strong family history, would be population screening. So there has been some work in this area, and 3 conditions have been considered tier 1 by the Center for Disease Control. That's Lynch syndrome, hereditary breast ovarian cancer syndrome, which is the most common form of breast and ovarian cancer and also increases the risk for prostate and pancreatic cancer due to the BRCA1 and 2 genes. And then familial hypercholesterolemia, which is obviously not a cancer syndrome, but it's also a very common condition where high cholesterol runs in the family and can lead to heart disease. These 3 conditions were denoted tier 1 by the CDC based on criteria that they are common in the general population, that there is easy testing available for the condition, and that they are actionable, that there's something you can do to intervene that would allow for a better outcome. So several ongoing projects have been testing the general public for these 3 conditions, and we're starting to get some of that data emerging. One of the studies doing this is the Geisinger MyCode project. And Geisinger is a large health system in Pennsylvania, and it's a closed health system, so they really have a lot of individuals from birth to death, and so they can also follow up to see if people do appropriate surveillance and if they are diagnosed with cancers after they test positive for these conditions. They found that 1.32% of their general healthy adult population had one of these 3 conditions, which is 1 out of every 76 individuals. And that really is a public health problem. When you think of newborn screening as the other time when we do population genetic testing, so you may recall that when you have a baby at the hospital, they prick their heel and test them for 27 to 30 some genetic diagnoses that can come out in childhood and that are actionable. The positive rate in newborn screening is 1 in 800. And the positive rate of screening healthy adults for these 3 conditions, Lynch syndrome, hereditary breast ovarian cancer, and familial hypercholesterolemia, is 1 in 76, much more common. A nice study out of Nevada called the Healthy Nevada Project was just published this summer, and it included 23,000 healthy individuals from Nevada that were recruited into a whole exome sequencing study. And they have first reported out the results for the 3 tier 1 conditions, and again found 1.26% had one of these 3 conditions, or 1 in 79. So very tight prevalence numbers very consistent with what Geisinger found in a very, very large population. I think very interestingly, 90% of these individuals had not been detected prior to entering the study. So they were not aware of their genetic diagnosis. Less than 20% had any documented suspicion for having the inherited genetic disease in their electronic medical record. And less than 40% had a family history of the relevant disease. So their take was that a population preventative genetic screening approach for people under age 45 may improve outcomes. And I would say for most of these conditions, this would really need to be in the late teens, early 20s, so that screening could begin when it would optimally begin and save the most lives. So we've had a great panel today with lots of really important points raised. We're starting to get some questions. Please continue adding them. Here are some kind of the take-home points from each person's talk, but we're going to go ahead and have everyone pop back on video and start taking questions now. Okay, and I saw one come through very early on for Dr. Karlitz. This first one was, are you able to do that analysis that you did, looking at different types of insurance coverage?
Yeah, I think, can you hear me? Yeah.
Yes. Okay.
Yeah, no, that's a great question because obviously there are going to be different screening rates depending on what kind of insurance you have. So that would be really interesting, but I don't think that you'd be able to get that granular with regards to insurance type in the SEER database. There may be other databases that you could use to potentially answer that question, but I don't think they would have the number of patients and the ability to look at yearly age like the SEER database. But it's a great question, and it would be really interesting. I didn't show this data, but we were actually able to look at that inflection in different states that we had some information on screening rates on, like which states have the highest screening rates. For example, like Massachusetts has a very high colorectal cancer screening rate. We saw a pretty good correlation between the states with higher screening rates having a higher inflection point from 49 to 50 compared to states with lower screening rates.
That's great. We have a question for the whole panel. Well, Dr. Gupta, you can try and take it first. Dr. Winder wants to know, will starting screening at age 45 add one colonoscopy per lifetime? He's seen arguments saying yes, that it would just add one per lifetime for most individuals, and arguments that have concluded no, that it may add more than that. Do we really know?
I don't think we know, and I think that based on the way follow-up is practiced, that it's very likely to be more than one. I think that we do have a problem with over-screening and over-surveillance, people getting recommended to repeat tests too frequently, especially after having minor polyps. And so I don't think it's going to follow the way the models are predicting, because it's hard to model the human behavior, and that's what's missing from the model.
Heather, sorry to interrupt. For the ZFINT staff, can we go ahead and do the gallery view for the speaker's presentation during this portion? Thanks.
Thanks, Caleb. Another question. This one was for Dr. Karlitz, but anybody who has an opinion on this can chime in. How should follow-up differ for individuals that have polyps removed at age 45?
Yeah, I mean, I can answer that quickly, and then the other experts could jump in. I would say the most important thing is to make sure that that polyp is not part of a syndrome where they're not average risk anymore. So it's interesting, intuitively, it'd be more concerning to find a polyp at age 45 than someone in their 50s, because there might be a higher risk of potentially developing future polyps. And more importantly, is there a syndrome present? So I think this kind of harks on the point of making sure that there's no significant family history that would indicate Lynch syndrome or another syndrome. Also, how many polyps are we talking about? Is it one isolated low-risk adenoma? Is it an advanced adenoma? Is it in the setting of multiple adenomas that may indicate a polyposis syndrome? So I think answering that question requires more knowledge of how many polyps are found, the type, the family history, et cetera. And I guess over time, as hopefully when we, in a standardized way, lower the screening age to 45, and we find polyps, we'll be able to study them longitudinally and understand whether or not the current surveillance guidelines apply to that population as well. But if anyone else has any points that I missed or.
Yep, we did a meta-analysis of the data that were available on the rate of advanced neoplasia among people who had adenoma under 50. And there's not enough data, but all of it points towards there not being a markedly increased risk in people who just have a couple small adenomas. So if there's no family history, if there's fewer than 10 adenomas, I actually feel like we should follow the standard surveillance guidelines that we use for people at age 50.
We have a question about whether or not there's cost effectiveness studies showing FIT is more cost effective in 45 to 50-year-olds, or are we guessing? Seems like we might miss the opportunity to prevent colorectal cancer.
There's a great paper by Yuri Lauterbom that Yuri led last year in Gastro. It clearly shows that FIT is highly cost effective. It's the most cost effective. It also showed that colonoscopy starting at 45 can be cost effective, but it was cheaper to do it with FIT. So at least as far as modeling goes, we're not guessing. And I think I saw a question about, cancer prevention. And in that modeling study, the colonoscopy at 45 seemed to prevent about 70% of the incident cancers. And the FIT strategy was modeled, it looked like, to prevent about 60% of the incident cancers, just sort of eyeballing it. So that paper's worth looking at.
We have a question for Dr. Gupta from a patient who has an MSH6 pathogenic variant, has extensive cancer family history, but only a single colorectal cancer at age 92 in her father. What do you think might be the best approach to address these hidden Lynch syndrome families with very few to no GI-associated cancers?
Yeah, but more data. I mean, we have to understand what's different about Lynch syndrome patients who never get cancer and those who do. And I think one thing we should feel more comfortable with is for people who have put together a run of, 5 normal colonoscopies done every year. For an MSH6 carrier, I think doing the colonoscopy every 2 years is safe. And if we're doing a high quality job, so I think that could be one early strategy, but we definitely need more data.
Yeah, and I suppose those are the very families that population screening might help.
Right.
Dr. Karlitz, a question about the abrupt uptick in colorectal cancer incidence at age 49. It seems consistent with detection bias, this person said. They said the data argue against a lead time bias or length bias. Why is this the case? Only randomized control trials can offer definitive evidence versus these biases.
Okay.
You're on mute. Okay.
Got it. So I'm off mute. Yeah, so I mean, the key issue here is whether there's a length time bias. And so that's when slower growing and potentially less clinically significant cancers are detected with screening. And in this case, as I showed in the stage stratification, we were finding, during this uptick, we were finding cancers that are beyond in situ stage. So if everything was found was in situ and those are easily removable by colonoscopy, then yeah, the length time bias may be a major issue here. But the fact that we're finding localized and regional cancers, that those are not innocuous incidental cancers. So certainly there could be a component of length time bias, but I don't think that's the major issue here. That was actually brought up by, in the review process for the paper. But if you read the paper, we go into that issue of length time bias. Now, the issue of lead time bias is different and has to do with the survival increase by detecting cancers at an earlier stage. And I didn't really show that data, but we did actually show a 10% increase in relative survival, 5-year survival from age 49 to 50, which is interesting. And that, certainly helps, with the merit of detecting these cancers, earlier from preventing them from or detecting them at an earlier stage. And in that case, there certainly may be a component of lead time bias, but that would be a different story than length time bias. So I hope that answers the question.
That's great. Dr. Siegel, one for you. What data do you have available on racial and ethnic differences in the early onset colorectal cancer incidence and increase, I suppose they're asking?
Yes, I didn't have time to show that today, but now we're seeing that rates are increasing across racial and ethnic groups, but they're really driven by non-Hispanic whites and American Indians and Alaska Natives. And the increases for Asian Americans and Black individuals are confined to rectal tumors, which is what we saw at the beginning for non-Hispanic whites. And so it'll be interesting to see now we're seeing actually in the last 5 years, rates are increasing for tumors in the proximal colon at the same rate as those in the distal colon and rectum. And so it'll be interesting to see what happens by race ethnicity and if that pattern is duplicated on down the road.
Thank you. I got a question from Robin Dubin from Alive and Kickin' asking how many more of these population health studies are needed until this becomes a part of the recommended guideline. So I keep wondering the same thing myself. I think the issue with the population screening for common genetic diagnoses is that nobody is quite sure how to do it. We don't have sort of a standard doctor's appointment that we all have to attend at age 18 or 20 at which this could be done. And young women are much more plugged in to the healthcare system in this age group than young men, but we would need to get this to everybody. So unlike newborn screening, where most everyone is born in a hospital and you have an opportunity to screen everyone with a heel stick before they leave the hospital, we don't have that capture point for young adults. And I think that is the logistical challenge that that is in front of us. The data appears to be stacking up pretty solid that it is frequently enough, it is prevalent enough that we need to consider this. I think no one knows how to do it yet.
Heather, I have a question.
For you. Yeah.
Can I ask you a question just to jump off of that? And maybe this is naive,
Please.
but why couldn't we do it at birth?
Okay, so that is a really controversial question. And I just did a podcast on this topic because they usually don't want to screen for adult onset conditions in newborns. With the idea that you should wait till the person's an adult and can decide on their own using their own free will whether or not they want to find out if they're at risk for this condition. And there was some concern also that if you diagnose a newborn, who's going to remember this to let them know when they're an adult and need to start the screening. But I counter argued that in fact, it's a really great consideration because most people of childbearing age are in their 20s or 30s. So you could catch the parent as well, since it should be one of their mom or dad is affected. You'd be getting 2 people diagnosed at that time period and in a really good age group where screening would start. The other thing is that both, actually all 3 of these conditions have a recessive form that's much more severe and does present in childhood. So if you have 2 BRCA mutations, you present with Fanconi anemia, which is a childhood onset condition that there is some management for. If you have 2 Lynch syndrome mutations, you present with something called constitutional mismatch repair deficiency, where we see leukemias and brain tumors in childhood, much more severe than Lynch syndrome. And again, there is management. And homozygous individuals for familial hypercholesterolemia need to start lipid lowering as toddlers because their lipids levels are so high. So I think that there could be an argument made for this, but it has been historically considered like a crazy idea. I think it's really, we have to start thinking about it. Great question. Switching gears a little, we've got a question for Dr. Gupta. Let's see, the one from Jim Hotz. Yes, if a patient younger than 45 presents with abdominal pain, what's the risk benefit of doing a FIT? And if positive, doing colonoscopy? Can the GI code that for rectal bleeding?
There's two pieces to that. One is, can you use a FIT to triage people who have symptoms that could be consistent with colon cancer or something else? And there's emerging data on this. There's a nice paper in Gut that came out recently where in the UK, they went about using FIT to triage, and it was very helpful for them in helping to rule out the possibility of cancer. Basically, they used a very low cutoff for the concentration of blood in the stool. And if you were above that threshold, you went on to the evaluation. It needs more study. And I don't think I've seen a study in the United States. In terms of coding, I think we're a little stuck. We have to go with whatever code, you know, if the patient has rectal bleeding, we have to code that. And if they have abdominal pain, we have to code that. So I think we're a little stuck there with using whatever the patient's presenting sign is.
Okay. We have a comment that it seems that 45 to 50-year-old age group is the current challenge, i.e. deciding how index screening should be done in this age group. Thoughts about this from the panelists?
I'm a fan of informed choice. You know, I think if we do it right, we have a conversation with people about at least 2 different screening tests, you know, 2 or 3, and let people choose for themselves. And you know, a person who wants the you know, these are your typical 45-year-old, you know, is, you know, both caretaking and trying to take care of themselves and, you know, working and whatnot. You know, a FIT may be the only thing they can work in to their schedule and maybe the exact right thing to do. And I think that we should be really careful to assume that just because we recommend a colonoscopy for a 45-year-old that they're going to do it or sign up in droves to do it. So I'm for choice.
Dr. Karlitz, looks like you agree.
Yeah. No, I was just going to say, no, I think that's a great point that Dr. Gupta made. And I would also make the argument, and this has obviously been stated before, is that we really have to think about screening, talking about screening before these ages even come about, before people are 45 to 54, just to maximize the screening rates in that age group. So I think this really has to be a conversation that starts much younger, obviously to make sure there are no, you know, syndromes present, but also just in general, if we're talking about average risk, just introducing that at wellness visits and things like that, so that people actually get screened at these ages.
That's a great point, and that's a good plug for our work group. The Early Onset and Family History Work Group of NCCRT has a project this year to do some market research on lead time messaging, because you're absolutely right. We have good evidence that you can't tell someone have a colonoscopy at 40 or a colon screening at 45 and expect them to do it at 45. They need to be told many times, as Dr. Jones likes to tell us, for many years prior to that, if we want it to happen on time. Dr. Siegel, Dr. Gupta is actually interested in what you think about the lead time, length time bias question on that big uptick, I think, at age 50 that Jordan found in the Sierra data.
Yeah, so I think there is a little bit. I think you can't say there's none, because the biggest jump is for localized stage disease. And we know that screening is more likely to detect the slower growing lesions. But as Dr. Karlitz mentioned, there's also an increase in regional stage disease. And there, I mean, I thought I saw a slight bump for distant stage too. So the bottom line is that there's a bucket of cancers there that could be detected earlier. And I would just add to what Dr. Gupta was saying about choice, that I'm sure everyone in this audience knows this, but people are much more likely to comply if they're offered a choice, and especially lower income people and people of color. And it'll probably, I'm guessing, be true for young adults as well, because it's just more convenient for them. So I think we really need to push those at-home tests more, especially for the under 50 population who are at average risk.
Can I make one point? I just want to underscore the issue of closing the loop, because I think it's an area where NCRT can have a role. I didn't have time in my presentation to just point out that of all those conditions, whether it's new constipation, hematochezia, every single one of those that is in a young person, those should all get better. I mean, if they have a chance to meet with a primary care doctor or a gastroenterologist and have an initial course of treatment, whether it's for irritable bowel syndrome for abdominal pain or fiber for hemorrhoids, all those things should get better. And I think we need to teach more clinicians that if it's not getting better, they need to follow up on it and really promote awareness among the public that they should expect to get better. And if they don't, they have to push their providers, their doctors, to think about colorectal cancer and getting more of a workup, because I think that can really help us avoid these tragic, prolonged workups, which just feel terrible when you have someone who's waited 150 days to find a rectal cancer. It doesn't feel good. It's not right for the patients.
Absolutely, and it leads to later stage diagnosis. So I think that's a really great point, that we've got to close the loop when these symptoms are found. If they're not better, do additional investigation. We're close to wrapping. I've got one more question from an individual who performs colorectal screening in a closed health system of serving Alaska Natives, similar to the Geisinger experience. He has a much smaller, he says, but in geographically dispersed population. He says occasionally he gets patients who have a strong family history who request colonoscopies at quite a young age, like 28, 30. He usually does. Please comment.
I would say I'm really curious about what's driving the patient's interest. Is it, my dad had colon cancer at age 35, where, that's a slam dunk, super easy to say yes to. When they say that, oh, my dad had colon cancer at 65, then I'm curious about, well, who else had cancer, what kind of cancers, and trying to understand really what's driving that. I think there's not a reason to deviate currently from family history-based recommendations for either genetic testing or initiation of screening. And I don't know, others may have thoughts about this too.
I would just say that rates are really high in Alaska Natives. I think, was it Alaska Natives that we're talking about? Yeah. So, and studies indicate that they have a much higher prevalence of adenomas as well. I mean, they're crazy high, and no one knows why. And it's assumed to be related to diet and maybe prevalence of H. pylori infection. But I think that population really deserves more attention. They're small, and so they don't really get it. But I think it's worth looking into deeper. I mean, when I was talking about differences in the trends by race and ethnicity, it's non-Hispanic whites, but American Indians and Alaska Natives have the exact same trend, rates increasing under 50 by 2% per year. So it's a steep increase, and there's something going on in that population. So I think it's worth asking more questions.
And the genetic counselor in me obviously would think that's an opportunity to see if that's a patient who could benefit from genetic counseling and possibly genetic testing. It makes me wonder if there might be a founder mutation in Alaska Natives that hasn't been identified yet. So we have come to the end. I am supposed to remind everyone of two things. One is Slido is apparently making a word cloud about each session. So if you guys can log into Slido and give a word or two that kind of sums up this session for you, we would appreciate it. We also are supposed to remind you that it is time to visit the virtual exhibitor booth. And what you will do in the CVent website is click join the virtual booth, and the sponsors actually have staff there waiting to speak to you. So please visit our sponsors, and thanks so much everyone for joining us. And thanks to our panelists.
Thank you.
Thank you.
Bye-bye, thank you.